So this is Dr. Spencer Krane, Assistant Professor of Urology. He got his medical degree at Tulane and multiple residencies and fellowships, Wake Forest, National Cancer Institute. And he's here to talk to us today about hereditary renal cancer syndromes. Thank you so much.
Thank you guys for inviting me. It's kind of fun to do this. I haven't done like a real lecture in a while, and it's like fun to be out and like teaching folks again because stupid COVID stuff. All right, let's see. That does go forward. All right. No actual disclosures relevant to this in any capacity. And then, all right. So goals of talk. First off, inherited RCC. So there's several different subsets of renal cell carcinoma, and one of the goals that we really want to talk about is helping to differentiate between those and understanding the genetic link between what the patient inherited and what the phenotypic demonstration of what they had. I think it's important to look at sort of the associated clinical findings in this because I see them as a urologist who patients come to see me with kidney cancer, but there's a lot of other things that are sort of subtle findings that are important to make sure that you're picking up for these patients. And then sort of at the end, what do we do for screening and follow-up for these patients? These are very small subsets of patients in general. There's not a lot of them out there. And so it's tough to really come out with really good guidelines as to what to do. But I think luckily through sort of collaborative work and the fact that there's not a lot of places that see a lot of this, we've been able to come up with at least a moderate framework that's safe and reasonable for patients. So like I was saying, kidney cancer is not kidney cancer. And that's sort of the most important subset about this, right? Like you have a patient who comes to see me and for 85–90% of renal masses that are detected in the US currently, they're detected on incidental findings. So you come into the emergency room, you say my belly hurts, everyone gets a CT scan, they find a 3-centimeter kidney mass, and then they send you for treatment. But that 3-centimeter kidney mass is not just a 3-centimeter kidney mass. It can fall into any of these major subsets of disease. And based on what inciting genetic event that occurs, it changes how we should be following and managing these patients, and particularly how we should be screening for them. By far, the most common subtype is clear cell kidney cancer. We're going to focus the most on that because it is the most common subtype, and it's also the most well-established pathway for genetic diseases. But there's a lot of other things out there. There's papillary type 1 and papillary type 2. And then there's this chromophobe oncocytomas, or hybrid tumor that sits between those two. Looking at aggressiveness, papillary type 2 is generally considered by far the most aggressive of these subsets of tumors. Clear cells are secondary, and then everything else is a little bit less and less aggressive as you move down the line. And that aggressiveness plays into how we manage these patients, particularly with hereditary syndrome. So the incidence of hereditary RCC and like who do we really need to screen? The problem is that these are not particularly common diseases, right? And so since hereditary renal cell carcinoma is not there, you really need very large epidemiologic studies to do this. And that's lacking, particularly in the US, because you get some better data out of sort of Northern Europe where you get socialized medicine and everyone has single payer systems. But here in the US with a lot of in between, it's a lot more difficult to figure that out. So who do we really need to screen? One of the great things that came about 10 years ago was the Cancer Genome Atlas. So they took some of the biggest institutions, the Mayos and the MSKCCs, and everyone sent all of their Michigans, all these places, sent all of their tissue into one group. And they did all of this genotyping, and they did it for all of the cancers. So they took about 400 clear cell kidney cancers, which is a huge number of patients, 270 papillary, 80 clear cells. And then they looked and see which subset of these patients had pathologic germline variants. And it is not particularly common. In clear cell RCC, only about 5 or 6% of patients had germline mutations leading to their disease. So the vast majority of patients probably don't need to be screened in any capacity, right? I mean, 95% of the time don't have any germline mutations. Papillary and chromophobe are a little bit more common, but still less than 10%, still not substantially. So how are we going to assess who needs to be screened? And bless you. One of the ways that they did this, and I think is kind of an interesting way of assessing this, is they took the patients and As Chris said, I've been at the National Cancer Institute before this, which is sort of where I grew a good interest in it. And at the NCI is where they really delineated some of these hereditary syndromes. And so they had a relatively large data set of patients who they could say, when was this patient first assessed and when were they first diagnosed with cancer? And what they found is that these patients generally got diagnosed in the early 30s for genetic syndromes when they were screening for patients. Well, then you compare that to patients overall, and you look at SEER data sets and sort of National Cancer Registry in about 16 or 18 states. And so they look at, and those subset of patients, generally about 80 or 70 is about when those patients get diagnosed. So you look at these two curves and you say, at what point of these 2 years is it more likely that you're on this side rather than this side? Essentially, they said 46, which is the most random and bizarre number that you hear in any of these screening trials, but that's really what's worked itself into the guidelines. Is age 46 is what we generally say. So if you're diagnosed under the age of 46 with a renal malignancy, that you probably need to be screened for this. I really like to offer. And this sort of hints at this. And one of the things that I want to say is it's just incredibly common. All right? You're looking at top 5 or 6 malignancies in men. It's number 6, okay? Once again, females, top 10, kidney and renal tumors, top 10 malignancies. So one of the things that I'm going to hit on later is that not all of these patients need urgent operations, okay? And that you hear the word cancer, and particularly with a lot of my patients, they say, well, I have cancer, but you don't want to do anything about it. But if you look at your incidence to mortality ratio, right, like who's dying of cancer, most patients who have kidney cancer aren't diagnosed and who don't die of kidney cancer. That's true. It's in the top 10 here for estimated new incidence. It's not in the top 10 for mortality for either of the two sexes. And that is partially because we find all of these small renal masses in people who come in for incidental reasons. And so a lot of it's diagnosed when it's localized as opposed to some of the diseases where you're more likely to find it due to symptoms. I think of stuff like pancreatic and liver disease or liver malignancies, they sort of present with those symptoms. These are not the most lethal of malignancies, and there are some patients who you don't need to rush to the operating room to remove these lesions on. And in the world of cancer, sometimes that's a little bit odd to say, but it's well established in the data that we are more likely to find these malignancies than people are to die of. Okay. When I say something weird or bizarre, please stop me. Any questions, please, it makes it a lot easier to interact with. Well, I guess these are the renal cell carcinoma guidelines. And this was published in the National Comprehensive Cancer Institute from April, or they call it the April version. But like I said, if you have somebody with a known pathologic variant with a close blood relative, these patients need to be screened. And that's obvious, right? But people with RCC who are diagnosed at or under the age of 46, which, like I said, is where those two curves cross in that NCI versus SEER data set, those are the subsets of patients with NCI. It is really common to have one kidney mass. It is not really common to have two kidney masses. And so patients who have either bilateral renal masses or multifocal disease, those are the patients who need to be screened for germline evaluations or screened for hereditary syndromes. And then any patient who has more than one first degree relative. There are some other sort of less, and these are sort of based on pathologic analyses. So if you have patients who, after you remove their kidney, they have an FH deficient or an HLRCC appearing or an SDH appearing tumor, and we'll get into that cell cycle stuff. We'll get into that. Those are patients who need to be screened as well. Or if they have AMLs and they have one of the other criteria for tuberous sclerosis, those patients need to be screened too. But like I said, age 46, which I think is particularly random when you look at screening things, it really is. It's young patients are the ones who get the hereditary disease. So von Hippel-Lindau syndrome, and this is, like I said, this is sort of the VHL, and this VHL gene on 3p25 is the most, I think it's the most understandable of these deficiencies. It's also the most prevalent. The prevalence is about 140,000-ish in the community. And so The way that VHL works is it works on a complex that degrades HIF. So HIF is hypoxia-inducible factor, okay? And what it does is the VHL increases the HIF degradation. So make this a little easier to see. There's a proline group on the HIF-1 alpha. And when your VHL is mutated, you are unable to hydroxylate that proline off of the HIF-1 alpha, and it does not get subsetted down for degradation. So when that happens, you get upregulation of a handful of other things that are downstream to it. Okay, and those things that are downstream to that. The last time I gave this was in 2019, and they had won the Nobel Prize for that year. Right? So the things that are downstream of this are HIF-1 alpha and HIF-1 beta are downstream of that, right? And hypoxia-inducible factors, as they sign, hypoxia means a lack of oxygen, right? So these are things that increase angiogenesis. They bring in, and so from a sort of a very basic understanding, you can see why this would cause cancer, right? I need more blood. I need more everything. These are cells that are extra supplied with additional nutrients, and these develop into malignant lesions. Okay, so there are a lot of steps along this pathway. And because there's a lot of steps along this pathway, there are a lot of medications that have been tried for patients with kidney cancer. And one of the very early precision-based therapeutics was in this pathway. So sunitinib was the first of these medications to be approved. And this was a tyrosine kinase inhibitor directed at this VEGF receptor, which is downstream. Okay, and this was one of the very early steps that we had made. And it's been used in a whole bunch of other malignancies because of the angiogenesis associated with other malignancies. But this was one of the very early therapies that was, we see a mutation in a gene. That gene drives this, we are going to do this. Okay, so after Philadelphia chromosome and CLL, this was sort of very much on the heels of that. And everything else along that pathway has since been targeted in some capacity. So bevacizumab is a VEGF monoclonal antibody that inhibits temsirolimus and everolimus. These are upstream of HIF-1 alpha. So if you can limit the HIF-1 alpha on the front end, you can inhibit that. And that's really been the mainstays of treatment for this, these malignancies. Yes?
So is this a treatment for the malignancies in general, not just those that are known?
So these are all treatments for patients who have metastatic disease at this point. And so sunitinib was initially presented because not all kidney cancer, 95% of kidney cancer that's clear cell has either methylation or mutation of their VHL. So there's inactivation of VHL. And so essentially all clear cell kidney cancer comes with that two-hit hypothesis of VHL1 out, VHL2 out, leads to clear cell kidney cancer. And so all of this was initially, the way that they found the VHL gene was they went back and they found families who had VHL and then went backwards. So all of these were tried in small subsets of patients who had VHL for kidney cancer, but are not particularly effective in that subset, and are currently used in the metastatic. VHL, because as I pointed out a second ago, this is a pretty ubiquitous gene, right? So VEGF leads to EPO production, is you have platelet-derived growth factor. There's a whole lot of things that are sort of downstream from this. So you get patients with VHL get a whole bunch of different manifestations, and kidney cancer is one of the most common of those. There's a whole bunch of other subsets of things that we see. So like I said, 70% develop that, but a lot of patients will end up with pheochromocytomas. So pheochromocytomas are sort of an upregulation of your adrenal glands, right? And there's even been some rumors that this feuding family from West Virginia, they had the Hatfields and McCoys. that some like direct relatives of the McCoys came to see Emory at some point in time, and they found like they found VHL mutations in those subset of patients, and like went back and decided that was all based on PHEOs, but benign that. But presentation is rarely renal masses. Okay, most of these patients will come in with other things, and so you will see them for other manifestations of that, or you'll see it. Most of these patients will have first-degree family members. The renal manifestations of this are mixed cystic and solid lesions, and they are generally low grade because if you're screening them as tumors are relatively small, they're not the most aggressively clear cell kidney cancers. They generally are relatively benign, but you need to manage them appropriately and sort of wait until they get to about 3 centimeters. And then once they get about 3 centimeters, then you're sort of need to clean out the patients from the disease. This is a lady who we operated on November and then December. And you can see, so here's her kidney, cystic, solid, cystic, 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 solid lesion, cystic lesion there on the left side. And then on her right side, cystic, cystic, solid, solid. I mean, they're essentially their whole kidneys get replaced by this. And so what happens is because these continue to develop in these patients will oftentimes require multiple operations. I mean, unfortunately for this lady, this was her 5th operation, and we were actually just removing her kidneys so that she could go on the dialysis list. After you've operated on someone's kidneys about 5 or 6 times, they're kind of done. And so unfortunately, that's what happens. And a lot of these patients end up progressing to dialysis with very poor renal function because there's only so much renal parenchyma that you can have remaining after you've done them to cut everything out. Yes. So during this operation, so generally, so if these patients are on good surveillance mechanisms, meaning that you're getting MRIs every year to 3 years, depending on growth size and patterns, when they've been removed at 3 centimeters, the cure rate's essentially 100%. And so they don't need any additional therapeutics or concern for adjuvant treatment with that. And so that's one of the important things about this is making sure that you're surveilling these patients so when they get to 3 centimeters, you can clean them out. Because I have seen patients who, for whatever social or other reasons, disappeared for a couple of years and then they develop metastatic disease. And it's really heartbreaking to see that because these are folks who could have not gone down that pathway. So there are multiple other manifestations of VHL. The most common, like I said, is clear cell kidney cancer, but also hemangioblastomas of the spine and the cerebellum are very common. These can also get paragangliomas in various other places not associated with renal glands, and the PHEOs are relatively common. Retinal angiomas are particularly common, and so the institutions that see these patients a lot will have the patients come in for a weekend or for 3 days, and they get everything scanned. And what we used to do at NCI was they would come in and they'd get an abdominal MRI, they would get a spinal MRI, they would see their ophthalmologist, and then we would check them for everything else if there was a history of that. They get urinary nephrins, they get everything. And because it is oftentimes some of these things are so small that they're tough to pick up on imaging. Chris, were you about to ask?
You had a lot of patients that had childhood cancer previously with VHL because they're not renal cancers.
Interestingly, most of these patients really don't present with like fulminant VHL symptoms or particularly needing renal tumor excisions until their mid to late 20s. And that's really, I mean, they'll develop some of the other issues prior to that. But in terms of the kidney cancer, it's really rare to operate on someone before 30 for clear cell kidney cancer or for VHL. The VHL Alliance, and you delve into these things, and particularly for rare diseases, it's amazing what the internet and Facebook have done for patients in terms of connecting to different groups. Is when you talk to people, make sure that you send them out into the world of good information and not into the world of bad information. But the good information that's out there is just unbelievable. And so for these patients, it is the VHL Alliance, because they can work together, has come out with some what they consider relatively stable guidelines for patients. And a lot of this is really based off of what can you do to prevent people from future loss. So audiology, because they get these endolymphatic sac tumors in their ears and they have trouble hearing, so you make sure that you see them. Like I said, the ophthalmologist looking for your retinal angiomas, and then everything else that you're looking for, the abdominal ultrasounds as kids get older, you try and get limit their lifetime exposure to CT scans, so you get MRIs or ultrasounds if at all possible, and all that ionizing radiation. And then there's sort of very special things that you want to do for patients when they're getting pregnant. If they're choosing to get pregnant, for most females, sometimes they don't even know that they have this, and they don't go through sort of the IVF pathway. Some of them will choose to go down that mechanism. So this is the first time this has happened to me, where I gave this lecture about 3 years ago, and I said, there's some cool stuff on the horizon. And then the next time I gave the lecture 3 years later, it actually happened. And that is like a very cool thing to see. And so, I mean, Dr. Harris is the back smiling because I'm sure he's done that more than once. But so this is a medication that had gone into phase 1 testing when I was still at the NCI. And it's a HIF-2 alpha inhibitor. And so I'm going to go back a couple of slides just to see where this is coming from. So once again, VHL, if you are inhibiting VHL, you get upregulation of this HIF-1 and HIF-2 alpha, which leads to this response, right? And so these are pretty ubiquitous things. They're in almost all of your cells, right? Because all of your cells need oxygen at some capacity. So what happens is, maybe we could target, rather than targeting HIF-1, target HIF-2. So this was a medication that was initially made by a company, Peloton. They got sold, but they started their phase 2 trial, and it just got published in the New England Journal last year, and that actually led to FDA approval. What they were looking at is they were looking at patients who had adequate renal function and treated them on trial with this HIF-2 alpha. Now, I don't know if you guys are aware of what this is called a waterfall plot. And what it does is it shows, they're very common in cancer journals, and the reason is it can show the amount of the response rate of their lesions. And so they were looking at the largest of their renal lesions, because like I said, all these patients have multiple tumors in their kidneys, right? And so when they do that, they were looking at what percentage of patients had that they were considered 30% objective response rate, and then the remainder had what's considered stable disease. Everyone on trial responded, meaning that everyone on trial did not have increase in their renal mass size. These generally grow in the 5 millimeters per year range, 3 to 5, kind of depending on age. The younger you are, the faster they grow. They saw they're in their full responders, and they consider anything greater than 30% to be an objective response. So that was 50% of their cohort. They saw that they went from increasing in size about 5 millimeters a year to decreasing in size about 5 millimeters a year. And that's an incredible number for these patients. It's really impressive to do that. The remainder of them were relatively stable. Now, these are pretty brutal drugs to take. 100% of patients had some variety of adverse effect. A third of them had a grade 3 or 4, which is sort of a severe adverse reaction to it. Interestingly, they had one death that was associated with a fentanyl overdose, unfortunately for the patient. But it's an incredible response rate for these patients, because we do a lot of partial nephrectomies, because like I said, kidney cancer is really common. What we do for these patients is not, they are in the hospital for several days. They have urine that leaks out from a third of the holes that we make in their kidney. It's a really difficult operation to sort of go through and to be put through. And so almost all of these patients decided that, look, this isn't very I don't really like this, but I really want to stay on protocol rather than having multiple operations on my kidney. And I think that that sort of speaks volumes for it. I mean, granted, this is 21 months of median follow-up, right? I'm talking about patients who are living 70 years these days. So you're talking about less than 2 years for this subset of patients. But this is actually came through as a groundbreaking drug for this subset of patients. It's the only drug that's approved in the space for VHL patients. They're looking at in other subsets, but it is like I said, absolutely brand new in the last 6 months for treatment for patients, which I think is pretty exciting. That's clear cell kidney cancer, VHL derived kidney cancer. Questions on that? That's exactly it. Now, when patients get sent to you, if you've seen it before, you know what a VHL kidney looks like, and you're not going to get sent a patient and be like, oh, that's because they all have at least 2 or 3 of the other manifestations of it. But yeah, no, this directly impacts clinical care, and that's very important. All right, moving on to papillary. So papillary RCC, like I said before, there's 2 sort of subsets of this. There's type 1 and type 2. And type 1 is generally slightly more indolent than type 2. And it's a little bit, and those patients tend to do a little bit better in terms of overall cancer-specific care. They are driven from 2 different subsets of disease. So PAP1 is you get increase in chromosome 7 or MET activation is generally what it is. And you lead with this MET activation, the MET's on 7q, I think, it's on 7q. And that leads to your activation. And these are incredibly uncommon. So hereditary papillary kidney cancer is just, I mean, I think that the NCI, I think they had 25 or 30 families that had it. And so it's particularly rare. It is, what's important about it is that the patients who end up developing disease on it, it's a different pathway. So papillary kidney cancer is driven through MET. If you have a constitutive activation of that MET, that's generally how patients develop metastatic papillary kidney cancer or papillary kidney cancer that's not inherited, as opposed to patients who have papillary kidney cancer with a germline MET mutation that causes their disease that causes their disease. And what I think is important about that is that when you look at how we treat patients, so these are patients in the metastatic setting who got treated with MET inhibitors. Okay, now papillary type 1 MET inhibitors. Now, if you look at patients with germline MET mutations and you treat them with a MET inhibitor, you can see at the bottom, as I show you guys more waterfall plots, all the way on the right, those are those patients who have these incredible responses to therapy. Okay, because they have MET germline mutations. They have constitutively activated. If you have no germline mutation, or if you have amplification, so instead of having 1 7q, you have 12 7qs in these cancer cells, you are not going to respond nearly as well to these therapeutics. And once again, this is how this drives clinical management in subset of patients. PAP1 isn't particularly common. PAP2 is not common, but substantially more important. And the reason it's more important is because it's incredibly more recent. And that's why we sort of focus on it. So PAP2 is generally associated with HLRCC, which is hereditary leiomyomatosis and renal cell carcinomas. This is an FH mutation, which is 1q, which is on fumarate hydratase, right? Part of the Krebs cycle. Nobody likes dealing with the Krebs cycle, particularly as you get as far away from biochemists as I do. But it continues to sort of haunt you as you move forward because you have to know the science in order to do this. This is substantially more common than type 1. And what happens is, once again, we're sort of back down to our friends HIF alpha and HIF degradation. But that's the normal pathway. When you get this disassociation, going back to where we were, this is HIF accumulation with clear cell kidney cancer, right? This HIF accumulation, more HIF, tries everything here. It's a pathway-driven response, right? And your body says, listen, I am this, the way they describe it is this pseudo-hypoxia, where you say, I'm starving, I need more blood vessels, I need more blood vessels. The same thing happens with HLRCC, right? Because upstream to this is where you get all of your energy for your cellular machinery. And so if you have no fumarate hydratase, if your fumarate cannot be transformed to malate, what happens is you get upregulation of everything prior to that. And if you get everything upregulated prior to that, your body goes into from aerobic to anaerobic respiration. And so if you're going into anaerobic respiration, once again, you're telling your body that you are in a hypoxic state, even if you're not truly in a hypoxic state. It's this pseudo-hypoxic state that drives that. And that's what drives the cancer cells. They say, oh my God, I need more blood vessels, I need more nutrients, and it increases the growth rate. And so that's the driving factor of HLRCC. HLRCCs, because they develop PAP2 tumors, these are substantially more aggressive than PAP type 1s or clear cell kidney cancers. And we don't go by things like the 3-centimeter rule of the subset of patients. In these patients, we really, if we see anything that's suspicious, we do oftentimes radical nephrectomies, removing the entire kidney, because their margins are, they will have infiltrative arms of the lesion outside of what you can see on the MRI. And they'll go 1 to 2 centimeters on the outside. The one thing that I ask all of my patients who have PAP type 2 is about uterine leiomyomas or about family members that have had hysterectomies at young ages, because those essentially are the same thing to me. And they're like, oh, well, you know, my mother had a hysterectomy in her 20s. And you're like, that is what you're saying. Because these, oftentimes women develop these very painful uterine leiomyomas. And that is, is almost 100% penetrance in this subset of patients. The kidney manifestations are substantially less common with these. The skin leiomyomas are hair, are small lesions that are associated with their hair follicles, and they can be incredibly painful for these subset of patients. When I was at NCI, where it's a lot colder than it is here, I had heard of patients moving from north to southern climates to get out of that. They tried things that would almost anything, because it was incredibly painful to have these leiomyomas on your skin. Once again, these are substantially more aggressive tumors. They are managed more aggressively. We don't follow 3-centimeter rules in the subset. All right, that's pathway. BHD, or Burke-Hall did that. So BHD is a follicular mutation. Folliculins on chromosome 17, it's generally whole chromosomal loss. These patient populations are substantially less aggressive lesions. And so they don't create these PAP2 that sort of will eat through your entire site. They create these oncocytoma / chromophobe lesions that sort of fall into this hybrid between barely malignant and barely benign. And some chromophobe tumors will metastasize. Oncocytoma essentially won't. Almost all of these patients will get these fibrofolliculomas, particularly along the bridge of their nose and on their skin. And you'll see these once people start to get about 30 years old, and they come up as a whole bunch of bumps along their face. They're not particularly painful, they're just present for this subset of patients. Interestingly, these patients will have cysts in their lungs, and they'll end up with these pulmonary blebs. And it's not uncommon for patients to have spontaneous pneumothoraces when they're growing up. So kids aged 20s and 30s will have been, oh yeah, well, I had a pneumothorax when I was in my 20s, and then they developed these tumors later after. Which is, that's just very uncommon. Renal penetrance is not very high. It's about 30% in the subset of patients. Importantly, that these tumors are unlike the VHL tumors. So I showed you the VHL tumors, and this is true for the papillary lesions as well. Those VHL tumors, those kidneys are chock full of tumors. Like you literally can't not cut out a tumor if you're there. Most of these patients will have one lesion. And I don't understand why, but most VHD patients will have one lesion. You clean them out, they're done. That's true for papillary as well, for most of the papillary subsets. There are some other sort of paraganglioma syndromes. SDH is another mitochondrial enzyme. It's associated with the Krebs cycle. So if we went back to that slide, we were 3 steps above it. And so you can see how mutations in SDH or SDHD can lead to these similar pseudohypoxic states, causing renal cells to develop. These are even less common than the rare stuff. I mean, this is like 10 families that we don't have things like this. But like I said, these are sort of upstream of everything else. Once again, leading to those pseudohypoxic states that drive TSC. Tuberous sclerosis is much more common than everything else. The good news for these patients in terms of their kidneys is that they rarely have aggressive renal lesions. Most of these patients with TSC end up with angiomyolipomas, which are benign renal masses. For patients with these benign renal masses, most of the time these days we don't actually cut them out anymore. We actually embolize them, and that it's a better pathway once they get up to about the 4 or 5 centimeters, or as patients are closing in on pregnancy because you worry about hormonal manipulations causing that. Autosomal dominant disease, you get a lot of other issues, particularly the brain tumors. And I think that there should be a list. So major and minor features associated with TSC. I think the rule is, I think they need 3 major and 2 minor or something like that. I think that's where they change the rules sometimes, but that's generally what it is. But if they have renal angiomyolipomas are particularly these are not particularly common AML kidneys, but you can see that this is your belly fat, and in the kidney you can see these multiple deposits of black. Those are the angiomyolipomas in these, and that's a particularly aggressive case of AML. One of the problems that will happen is that these will become painful. Your kidney has stretch receptors, and as these continue to enlarge, you'll have some pain associated with it. And I have seen that in a handful of patients. Going back from the end, so this is upstream of mTOR, right? And so by inhibition of TSC, your mTOR pathway, which is one of the major cellular growth factors, is unregulated, leading to cell proliferation. So there are some treatments for patients with TSC directed at their renal lesions, and they're all mTOR inhibitors, which hit this subset. The most common of those is everolimus, or sirolimus is actually one that they use in transplant, but everolimus is the one that's been most studied in the TSC and AML population. They're not particularly effective, and patients particularly hate them. So I haven't been able to keep anyone on it, but that's generally where those are. These patients, because of their tubers in their head, they do have some neurologic deficits for a good percentage of these subset of patients. And they'll lead to either, whether it's seizures or autism spectrum developmental disorders. So BAP1 is BRCA-associated protein 1, and this comes in sort of it's a different pathway than everything else. The reason it's a different pathway is it's a very different, it doesn't lead to this pseudo-hypoxic state. That said, I've grown to have an affinity for it because I have one patient who I've operated with at this point. And so what happens is these patients with PAP1 tumors, they end up with some of the other malignancies that you wouldn't see in other subsets. And those would be your mesotheliomas and your melanomas in the BAP1 subset. And so these patients are, like I said, particularly uncommon, but this is a lady who came to see me, she told me four years ago, I guess at this point. And she had a left radical nephrectomy with an outside provider, had a new solitary kidney and a new renal mass. She was like, oh yeah, I had a couple of melanomas removed when I was like 18 or 19. And the reason we do this is for this, right? She BAP1 pathologic, and this was, so you can see this is her tumor at the time when we took out her first of her tumor. So this is her tumor here. You can see she doesn't have a kidney on this side at this point in time. That's why we screen them. It's because of ladies like Michelle. I mean, she's now a huge member of the Kidney Cancer Association. And I think orange is their color, and all of her Facebook posts are her. There's a handful of other things that are even less common. P10 is one of these. P10 is upstream of TSC and mTOR. Once again, macrocephaly is really what you see with the subset patients. They have really big heads. There was one family that we saw at the NCI when I was there for 2 years. Really big hands, too, really big. And then there's some things along the mitochondrial transport pathway that will lead to less common disease. So, importantly, like I said before, these are different subsets of diseases. And because they fall into different subsets, we need to follow them differently. So this is the NCCN guidelines, and particularly for renal masses. And I think that it sort of shows you severity of things in a little bit, right? Because when you have patients who are BAP1, you're going to be following them at least every 2 years, starting at age 30, as opposed to patients who have VHL, where you're going to be sort of starting for everything at age 15. I think it sort of speaks to the clinical association of all this stuff. Patients with HLRCC, we start screening them at age 8, right? I have a girl who just got pregnant. Thank God she didn't have anything. She got an MRI right before she got pregnant, and she was due for her next one. She's like, oh, I was like, Amber, what the hell are you thinking? But the next time we did it, she had something a little bit suspicious on her follow-up MR. Thank goodness the next MR was fine. But these patients need to be screened, and they need to know that this is particularly difficult. It's a little different in real world settings for this, because life happens, right? And so, like I said, patients get pregnant and they miss their follow-up appointment. COVID happens and you don't see anyone for 2 years, right? I mean, and so ingraining in your patients when they're young that you need to make sure that this remains a priority for you, and you need to see this. Because like I said, every so often we'll see a patient who falls off the protocol, and when they come back with lung mets, you're like, look, I can't cure you at this point in time. Like, we're talking about systemic therapies that you will need that won't actually cure you anymore, as opposed to somebody who, as soon as they get to 3 centimeters, you clean them out, and then it sucks, but they're done. Questions? Concerns? Mm-hmm. So I think so, right? I mean, the way that it was always explained to me is you essentially use it like you use partial nephrectomy, which is you give it to somebody for a year, maybe 2 years, everything shrinks, slowly grows back up, and you're like, all right, it's time to go back on medication for a little while. And to me, it seems like a pretty reasonable way of doing it. I mean, being on something with 100% toxicity, with a 30% grade 3 toxicity or above for the rest of your life, look, I take a couple of partials over that, to be honest. And that's as somebody who hates doing partials on VHL patients. But yeah, no, that's sort of physiologically, that seems to make more sense.
So is that a discussion you want to have with patients as far as the access? Is that something that they take, or like decide based on the situation?
I mean, there's hard and fast rules, right? Like the hard and fast rules, look, your renal mass is 3.3 centimeters, you need to have surgery. Where it falls sort of before that, I think really is going to be clinician and patient dependent. And sort of how, sort of risk tolerance and a lot of things. Although that medication is insanely expensive. I think it's close to $20,000 a month, right? Which is just, I mean, that's, yeah, I mean, it's astronomical, right? Like these orphan disease things are, they're just so, I mean, which I understand it's expensive to make them, but it is also, very few of my patients can afford the copays on $25,000. I think almost none. Yeah. Yeah.
There's then no 7-year-old because we know.
So yeah, exactly. So those are going to be in HLRCC, those are PAP2 tumors. And those PAP2 tumors are just substantially more aggressive than everything else. And since they're more aggressive, and like I said, the MRI will underestimate margins. And you can even see it on the ultrasound if you're doing, because when we cut these out of patients, we'll put an ultrasound on them just to confirm that we're getting a good margin. And you, even on top of that, we'll take another centimeter margin just to be safe with HLRCC tumors. Those PAP2 tumors are really, they're very bad actors. And there's also less good systemic options for those patients if they do become metastatic.
Thanks, Dr.
Yeah, no, thank you. I really appreciate it.